So, Lavan, thank you very much for joining us. I'd be very grateful if you could introduce yourself, and then we'll have a chat from there.
Great. Hi, everyone. It's a pleasure to be with all of you today. So thank you for inviting me. So as Tim said, I'm Lavan, GP in Sutton and Croydon, just because I get bored doing one kind of job. So I like a couple of areas. And thankfully, your team, so Physio, helps us in both areas, both in Sutton and Croydon. I have very good experience in Croydon more. We have James, who's part of your team, who helps us out on Fridays. So really, it's a thank you to Surrey Physio, because they've literally game changed general practice for us in the area of Croydon, because our days are amazing. Even Dad, from traditionally seeing patients, has already seen such a big impact of our first contact physio. So we're really loving it, and the patients are loving it. So we want to thank you guys as well. So it's a pleasure to be here to give our thanks in a way.
So, Lavan, one of the things as FCPs we do struggle with, and I know this from personal experience, is really understanding the really common things with blood tests. Now, I mean, I can spot the basics. I know a little bit about my CRPs and my ESRs, but to be honest, it's just like gobbledygook to me. I was wondering whether you could just talk us through some basics, because we're going to make this probably a two-parter. Certain things we should look out for. What do they mean? What are the common trends with, the tips and tricks with knowing the certain blood tests and understanding them? Over to you.
Absolutely. Thanks, Tim. And yeah, that's a good way to start. I think it's important, we go one step further even and pick up those even subtle things that you guys are more than capable of. I mean, these are things we're trying to teach some of our medical students. So just think slightly outside the box when you see a blood test, which will help your management of the patient. And the reason I want to talk about that is actually things like platelets, for example, or ferritin, i.e. iron, which you may see some of us doctors request, where you may say, oh, the doctor's just looked for vitamins, so he's looked for things like iron. But interestingly, iron, if it's raised, can give an indicator of inflammation, and therefore could help you with your diagnosis. So we'll go into that deeper, but let's start kind of on the basic level, and obviously push me on further if you want to jump through it. But it's good to get a basic understanding of how I see it, because it may be different to how you see it. So typically in the kind of work you guys do, obviously if it's very practical, that's easy for you guys, you just get on it. And it's the stage of when we request blood tests. It's really why we're requesting blood tests. Now, a little secret from us is sometimes when you see these mass lists of blood tests doctors order, that should be your indication that we don't have a clue what's going on. We are stuck ourselves. So when we're doing, when I do vitamin D, I don't have a clue. And I'm really banking on that being low, because 50% of the Croydon population have a low vitamin D. So I know if this patient is coming in every day, if I get that, positive, where they're getting vitamin D of say 12, I know I can put all my eggs in that and say, look, go away for 3 months, take vitamin D, and then see me. So there's a trick for you just to watch out for when we're doing lots of blood tests. It's not because we're clever, we just don't have a clue. Now, with the depth of it, it's good to break them down into our standard or our routine blood tests. And now these are things like the full blood count, FBC, your U's and E's, your LFT, and interestingly, thyroid. So your TFT does fall in that category. We do see lots of muscle ache, joint pains, especially in the quadriceps area and shoulders. That could be a sign of hypo or low thyroid disease. So as a GP or a doctor, our basic bloods, full blood count, U's and E's, LFT, and TFT or thyroid. You should see that quite regularly, and you are more than comfortable. We'd be more than happy for you to order those if you needed, and no one would scrutinize you and say, oh, why is that cost? Because actually all of those, if you really think about it deeply, could affect muscle ache, joint pains, and try and find a diagnosis from them. So those are your basics. From there, where you guys jump in more, is more sensible to consider, like Tim was mentioning, about the ESR and CRP. Again, ESR and CRP is a tricky one. Most doctors, we try to avoid going down ESR and CRP. You probably see us, we're trying to reduce why we do it. And the reason is it opens out a can of worms. if I were to punch someone in the stomach, if someone was pregnant, if someone tripped over, if someone went for a quick run, ESR goes up. And so we're in this really tricky situation where I could get an ESR and get an ESR of say 50, which is a decent level. And then it's a whole headache because this patient probably came in for a bit of a chat, feeling quite low about something, say they want routine blood tests, and my colleague has accidentally put an ESR, and we're in a whole difficult place where we now have to investigate, why is that ESR raised? Could it be a gastric cancer, cancer of the stomach, which I picked up a stomach cancer just from a simply high raised ESR and looking into it further. So you guys probably have to, and quite frequently will have to do your ESR and CRP, because they've come in probably with an inflammatory problem or a painful problem or an ache somewhere, which will cause it to rise. And the reason why you guys should be doing it more is because you want to monitor progress. It's one thing the patient saying, oh, Tim, that was rubbish, your session didn't help me at all. But actually, if their ESR is dropping month by month, there is an indication whatever Tim is doing is actually probably helping if we believe that the ESR and CRP is responding to the physio. So you've got your basic blood test and you've got your ESR and CRP. Now the question comes is we have to start thinking a bit cleverer. And normally my next group, which I normally attach onto and I do regularly for anyone with musculoskeletal pain, is vitamins. B12, folate, ferritin, vitamin D, these are all, if they're low in any way, can all encourage muscle ache and joint pains. I just had a blood test last Thursday, a hemoglobin of 5.4, which is ridiculous because most levels should be about 11 to 14. This lady's walking quite comfortably around. Her hemoglobin is low and her iron level is low. Now, the reason she came to me is because she was getting musculoskeletal pain in her upper thighs. There was nothing else. This woman probably heart is struggling moving her body, but all she came in with muscle ache. And initially, my colleague, who's actually previously a physio, who's now a physician associate, initially thought this was a quick physio problem to bring her in and examine her, and only subtly picked up signs there could be something else going on. Did all the bloods except the red blood and iron, which came back abnormal. So you can see, even in your kind of work, iron, if it's low, can cause muscle ache, joint pain. What's really important is with what you guys do as well is remember, anything you guys do, as fantastic as it is, which we know, won't fully work if the vitamins aren't on top level. So if your vitamin D, your iron, your ferritin, your folate, if none of those are on maximum or a decent level, these regular patients that come to see us that complain of all over body ache, I've seen the physio, my back, he did a bit, it did help, but it's not quite there. Don't be disheartened by it. You guys are probably doing a great job, but the baseline isn't there. You're working from a level of low. And actually what a trick you guys should try and encourage is get their vitamins up, which I'm sure you guys do, but really nudge that. And if it means doing a blood test to prove to them, because some patients need that visual, my iron is 4, oh, great, my vitamin D is 12. Mate, you need to really get those up, because whatever Surrey Physio tried to do, then they're going to be not working as well if we can't get it. It's similar to how you guys sometimes see patients who are in extreme pain and they say, oh, I need a physio, I need it today because I want it done. Well, how can you guys do your magic if they're not even able to move because in so much pain? Sometimes you've got to give them that nudge to get the flexibility of movement going so that they can get on and let you guys do your work. So vitamins is a really big part, and don't feel worried or concerned about adding that or seeing doctors who add on vitamins as part of their musculoskeletal kind of routine bloods. That's one section. And the last real one is where we really go outside the box. These are the ones that, even as doctors, some of the junior doctors and even me have to, nudge my head a few times to remember. But these are the weird and wonderful things. Now, even simple things like gout count as weird and wonderful because we don't routinely test for gout. So urate in some places, or uric acid, that's the blood test you're looking for. And what's interesting, this tradition of the King Henry VIII, the fat white gentleman who drinks loads of red wine and red meat, it's not like that anymore. I've got females that I'm diagnosing with now, which I'm sadly faffed around with for 3 months and just thinking, why is that not right? Okay, let's just do a urine. I'm sure it's going to be normal. And it comes back high. and you're thinking, right, these urate crystals are flowing all around the body, they go everywhere, and they're depositing in areas, not your typical big toe on your foot, but actually in the fingers or in the elbow or in the wrist. And actually, that is what's explaining it. You then start them on medication known as allopurinol, which drops the levels down, and suddenly they're in love with you. They think you're the greatest person that's ever walked because they've been suffering for so long. So uric acid or urate is another great blood test that I think you guys should get to the process of requesting regularly, and there's the reasoning behind it. And then obviously comes the big players, so our rheumatoid arthritis and autoimmune conditions. Now, with rheumatoid arthritis, you may know rheumatoid factor is the blood test, which we traditionally used to do. Interestingly, that's not actually the most accurate blood test. We have rheumatoid arthritis patients who are negative rheumatoid factor, but have rheumatoid arthritis, and vice versa. The most accurate blood test we have is called anti-CCP, which you can request on our blood test forms, and that's a more accurate level. And as sad as it is sometimes to diagnose or pick that up on a blood test, really, really important we have that, because it gives us a kind of a way out now to show them how we can actually mend their problem. Yes, it does lead to kind of fancier medications, but their quality of life can dramatically improve. An interesting blood test also is something called ANA, A-N-A, and this fits in with all the autoimmune, and that's as far as you'll need to go. And with ANA or ANA, things like a condition called Sjogren's, which is due to lack of teardrops coming from the eyes, as well as dry mouth, which actually is linked to musculoskeletal problems, rheumatoid arthritis, juvenile chronic arthritis, polymyositis, all of these kind of weird and wonderful rheumatological conditions, they fall in that. And where I don't want you to, feel like you need to diagnose these, adding the ANA blood test, ANA blood test, it will give a list of conditions that it's positive or negative to. And that doesn't mean you have to do it. It just means you're loaded with more information to pass on to GP colleague or even the rheumatologist to say, guys, I don't know what's going on, because actually most doctors don't even know what's going on, but there is something going on. There's an autoimmune process going on here where the body is attacking joints, and therefore, I don't know where we're going with this, and actually you guys are the best guys for this. Can you look into this further? So I'll just break or pause there just to kind of, because that's a lot of information, but that journey, and just to summarize, patient comes in, we'd start with the basic bloods, which we do routinely, full blood count, U's&E's, LFT and TFT, because all of those could be linked to muscle ache joint pains. We then move on to the ESR and the CRP, which, like I said, in your case, you're allowed to kind of overly use, because actually there is an understanding why. And then we've got things like the vitamins, so your ferritin, folate, vitamin D, and B12, which can all cause muscle ache and joint pains. And then really go out there to starting on the level of urate and uric acid for gout, but as well as rheumatoid factor, things like ANA and anti-CCP. We'll talk about ferritin, the clever stuff with ferritin and platelets in 1 minute. But just while I pause there, is that kind of roughly the path you're happy with taking in terms of discussing, Tim, or is that a bit off key?
Yeah, that's great. So let's just go through this. So FBC is full blood count. Now, when I see these popping up, they confuse the hell out of me. I mean, there's neutrophils and white blood cells and red blood count, and do we have to worry about those breakdowns? Because you often see discrepancies in those, especially in certain population groups. I mean, what is that really telling us?
So a good question. So yeah, let's start with the full blood count. When you get that list, there's probably, I off the top of mind, about 12. I did hematology in hospital, and even I still don't remember what each of them are. RDW, the width of red blood. Why we need to know that is beyond me. Why it needs to be printed out is beyond me. But there are certain ones that you should keep in your mind. So it's the hemoglobin, HB, is very, very important. The WCC, so the white cell count. The neutrophil, so and I'll tell you what that is. The platelet, and lastly the lymphocyte. and I can explain all of those. And those are really the ones you should look at. Everything else, in the most respectful way, chuck them away. With HB, that does marry what we were speaking about earlier, that the real time you really need to know is when it's really low. High is not a big deal. Yes, if you're being very pedantic, it can increase the risk of clots, because the theory is you've got loads of red blood running around your body, really thick and heavy, and therefore it can be a bit sluggish, and it doesn't allow for good blood flow. But ignore the upper end. The lower end is where you'll have to be a little bit more cautious. So when the hemoglobin is low, just remember, even for physio, if they've got a very low hemoglobin, they're functioning on lower capacity, they're not going to be able to do, the exercises, the movements, as much as you would normally like to do. So that's your hemoglobin level. The white cells and neutrophil, they go hand in hand. Neutrophil is for bacteria or bacterial infections potentially. So when your neutrophil is raised, you typically see your WCC or white cell raised. All that's indicating is when the white cell is high, the body is working hard to fight infection. And you look at the neutrophil just to check, that's risen. So they've got a bacterial infection going on. Why is that important? If they've got a UTI, if they've got a chest infection, if they're septic, you're not really going to go very far with this. I'd hope you wouldn't see it frequently, but say, for example, they have a septic arthritis, you would expect the white cell to be raised, and you would expect the neutrophils to be raised. It would be in a really bad place if that was the case, because we're running out of time. That's not good when it's entered the bloodstream in a septic level. But yeah, white cell and neutrophil, when they're raised, that would indicate there's an infection. In a small population, so the Afro-Caribbean population, they have something called ethnic neutropenia. Not a lot of doctors know this, so it's good you guys just having an awareness, and especially various areas. I know in Croydon, a lot of my students have all panicked and come to me going, oh gosh, their neutrophils are low. Is that a worry? No. Ethnic neutropenia, it just happens to be in Afro-Caribbeans. In generally, their neutrophil and their white cell count is a little bit lower than the average. So compared to their Caucasian colleagues, it will be a little bit less. That's nothing that we panic about. That doesn't mean they can't fight infection better. It's just the way it is. So if you ever notice that, just watch out for that. And the last extra bullet point, just for kind of extra brownie points, just to look very clever in front of your colleagues, is white cells very marginally rises when a woman is pregnant. I made this mistake as a GP registrar, so I actually qualified as a medical student, somehow didn't learn that bit, but I was getting lots of pregnancy blood tests back going, oh my God, they must have an infection, they must have an infection, because their white cells were all marginally raised. No, when a female is pregnant, the white cell goes slightly up. So if you're seeing a lady, for physiotherapy for their pubic symphysis or something, and for some reason a blood test there, don't worry if you notice their white cell is slightly raised. That's allowed, it's acceptable. It's not because they've got a UTI, it's because they're just pregnant.
And did you talk about platelets and lymphocytes?
Sorry, yeah, let's get onto that. So platelets, a very interesting one. Now, platelets is becoming a big deal. Platelets is what we call an inflammatory marker, similar to how ESR and CRP is, and when I go on to it, how iron is. It rises when there's inflammation in the body. And now, why do we need that? I mean, it just complicates things, but it is a very good marker. So patients who, for example, have a big operation of their tummy, when you do a blood test immediately afterwards, their platelets will be out the roof. Because if you really think about it logically, what's happening? We've made an incision, healing is taking place, the platelets are running in there to seal the area, and then you're getting your clotting factors and the process continues. Now, what's interesting is that is also a sign of an inflammatory marker. If there is a tear or a damage, so say in the knee or in the hip area, the assumption is slowly platelets should rise, because platelets should be arriving at that site, trying to heal the area. Why you should be a little bit cautious is, sadly, and not to bring up cancer and such a sad topic, but cancer is rife. It's in 2020, it's now they're saying 1 in 2 patients will have cancer. Now, you're going to be picking up random cancers, or you're going to be picking up things that could be suspicious of cancers. And we now have, as doctors, a teaching for ourselves called Lego C. Lego C is, if your platelet count is raised, you should think of Lego C cancers. That's lung cancer, endometrial cancer, gastric cancer, esophageal cancer, and C, colon cancer. Lego C. I'm not saying you go into that depth, but these ideas should be coming. Even if you feel comfortable, and you should feel comfortable, knock on one of our doors. If you ever see a platelet raised very high, so it should be in the kind of 150 to 400 range. But if you see a 700 blood test for platelet, you're not sure why, speak to one of us. We'd be so grateful if you did, because you may be at the start of picking up a cancer. And again, since the idea or concept or understanding has come, we're picking up more and more cancers simply based on a platelet rise, nothing else. And they've come in for body ache, muscle ache, headache, having a chat from low mood and just wanting general bloods. And that has led us on a journey to pick up a cancer well before it's even established. So the reason I'm pushing that to you guys, yes, it does apply to you guys because inflammation, inflammatory markers, yes, that fits into your jurisdiction, but you guys are better than that. I would say even have an eye out that if it is raised significantly, speak to one of us, because we may be onto something.
And what was normal levels? So 700 would be considered high, but a normal is what, 450?
150 to 400.
Okay.
Is things. So you get low platelets. Some people have some conditions, a condition called ITP, where your own body attacks it. That obviously needs our attention and our help, but it's the higher ones that are now becoming the fashion or things we should be jumping on.
And what does LEGO-C stand for? So lungs?
Lung cancer.
Yep.
Endometrial cancer, so the womb. G, gastric cancer. O, esophageal cancer. And -C, colon. LEGO-C, we call it. And we've got tools. We've got tools now that we're so on it now that, you know, we've even got a program that now, whenever it literally pops up on EMIS, it will say platelets high. Have you thought about cancer? That's how important that blood test is for something that, if you asked me 10 years ago, Lavan, oh, this platelet's risen, I would have gone, oh yeah, wonderful, move on. You know, next thing. It's really a big deal now. So do take some pride in the blood test ordering, and if you do follow it up, be honest and have that discussion with us.
Lymphocytes.
Lymphocytes, yeah. It's a simple way of saying more viral. So some of these conditions, so COVID is a great example with what we're living in at the moment. COVID, typically you'd see a rise in your lymphocytes. It's your viral markers going up. So, you know, in typical sore throats, you wouldn't do that for everyone to try and prove to a patient's viral, because it doesn't always show up because it's so mild. But these big ones, Epstein-Barr virus or a glandular fever, so these young teenagers going out clubbing when they used to, kissing everyone and passing on their glandular fever to everyone, that, you know, they get quite significant sore throats, and they get very unwell with it. And, you know, not only do, say, liver markers go up, but interestingly, their viral or lymphocyte marker jumps up. So it's an indication. It's probably out of the ones I've mentioned in the full blood count, not the most important. But again, like with everything, if they are raised, you could be a bit softer on your approach with that patient on, you know, they must be a little bit unwell for their blood counts to show a rise viral load, and therefore, you know, in the nicest way, let them off a little bit. If they're not coming to their sessions for physio, you know, let them rest a bit till they're ready.
What about UNEs?
Yes.
Can you explain the importance of that, and when should we be checking for that, or is it just a standard routine bloods that's included in, and why might we look at that?
Absolutely. So UNEs, in one sense, I guess, shouldn't really be used as any form of screening or help in musculoskeletal. Yes, in a really weird and wonderful, have they got some chronic kidney disease that could be causing it? But I think for you guys, it applies more for medication. When can we give, you know, NSAIDs, ibuprofen, Nurofen? Well, we know that it does cause gastric reflux. We know that it causes burning and potential ulceration and bleeding. But a big problem it causes, it puts people in renal failure. It can kill your kidneys. And doctors are frequently, you know, culprits of this. You know, we start at the age of 50, naproxen 3 times a day. They then decide they just want to keep using it. We give repeat prescriptions, and we watch, sadly, their kidney function deteriorate. And for you guys, even more important is actually, say they're 65 or 70. Now, we make that call sometimes. They may come to us and go, Dr. Baskaran, I've been using ibuprofen because it's the only thing that works. We hear it all the time. We know how good it can be. But really, we need to, if we're going to allow that to happen, which actually there are exceptions, you may get a fit 70-year-old who says cocaine was a waste of time, tramadol was a waste of time. I don't want any painkillers. The only thing that works for me to get on with physio to finally get my treatment sorted is ibuprofen. We really, really, really should be doing a use-and-ease, and that's to check for their kidney function. Because if they've got good going kidney function, then wonderful. But if they haven't, we should be in an even stronger position to say, you really need to stop. And you can use the words as, we are killing your kidney if we carry on giving this, because you are damaging the lining of their kidney. The two blood tests, the two parts of use-and-ease, which is vitally important. I mean, potassium, sodium, you know, yeah, they can fluctuate. Yes, we need to watch out for those, but it's the creatinine and the EGFR. Now, annoyingly, they're kind of the numbers are the opposites of when we look. And what I mean by that is with the creatinine, it shouldn't be more than really 120, especially in older people. If the creatinine is rising, it means that you are worsening your kidney damage, and therefore they're getting worse and worse into kidney failure. We have patients, you know, in the 200s, 300s that I sometimes have to send into hospital. So they really should be under 120. Really, people like us should be in the 60s, 70s, that kind of reason. So creatinine should go no higher than 120. And annoyingly, the opposite is for the EGFR, the way the kidneys filtrate. The filtration should be higher than 60, and you'll see that because everyone generally, like if we hopefully blood test all of us, we just say over 60. They don't give any more numbers than that. They just say over 60. But kidney failure it goes down, so 50s, 40s, 30s, 20s. When you talk about, say, 15, you're talking about people who are on dialysis. You don't need to know the technicalities of, because each stage they do it in tennis numbers, so kind of like 40, 30, 15, and they're the different levels of chronic stage, which is it's no need for that. You just need to know EGFR. If it drops below 60, be very cautious about giving NSAIDs, and to that extent, other medications, so things like methotrexate, which we give in rheumatoid arthritis. It's really for like a barometer for you to understand, almost taking some interest in the medications they're on for their pain. Maybe you should talk to your doctor about this, because I have a suspicion that your kidney function isn't top notch. Are we making it worse with this medication? Please speak to your doctor to discuss it. By all means, please have that initial conversation, but that's where the kidney function, not necessarily for muscle, leg, and joint pains per se, but really more for medication.
So we're all clear. Just explain what exactly do use-and-ease stand for?
Yeah, urea and electrolytes, and it's what it says on the tin. So urea, it is basically the byproduct of red blood cell that gets broken down and kicked out the kidneys. If we're dehydrated, it goes up. If we're bleeding, it goes up. So it's a sign of inflammation. It's very useful. And electrolytes, as we know, sodium, potassium, the kind of Gatorade and all those kind of drinks that we may do, they're very important, because interesting, if they're off, so if your potassium or sodium off, it can cause you to have seizures, it can cause heart rhythms, it can even cause a heart attack. So they're vitally important. But yeah, absolutely, for monitoring and bloods for medication.
What is LFT?
For LFTs, yes. So LFT, if we break it down, and if you're interested, there's four. I'm thinking about the area, my Croydon area, where we have patients drinking alcohol from the age of 13 and excessively coming to our surgery, you know, pissed out of their heads. With having alcohol as a problem in our area, it's important to talk about liver. So I think the main ones to talk about in LFTs, so liver function test basically, is something called ALT. And in some areas, depending on where you work, it's an AST. Either way, it's the T, which stands for transaminase. Now, it's good if you can image it in your head, because it's a lovely thing if you really understand. I was teaching my pharmacists the other day, and they really appreciated the time to explain the difference, because it can give you a bit of an idea what's going on. So anything where there's a T at the end, AST or ALT, means there's damage within the liver. Now, where that applies for you guys, things like methotrexate, highly poisonous for the liver. So if you pick up a raised AST or an ALT, warn one of us, because actually we need to stop that methotrexate. There's a possibility that's making it worse. Interestingly, where it applies to you guys as well, simvastatin, rosuvastatin, all the statins can potentially cause liver damage, can potentially rise ALT, and they could be coming to you, or we lazily could be just chucking them to you when it's something as simple as we need to stop your statin, because that's actually what's causing their general muscle ache and joint pains, which you may come across. So AST, ALT is within the liver, always remember that. And then there's ALP, so phosphatase, that's around the liver. Now, examples of that is where, sadly, if you have someone who's got, say, pancreatic cancer, if they've got a gallbladder cancer, if they've even got a gallstone. And if you think about the anatomy, or if you ever see the anatomy, it's the liver that sits, just say, and you've got the organs around it. So you've got the pancreas just sitting up on top of it. You've got the gallbladder sitting on top of it. And the reason why we talk about it as an external is because when there's a pressure, the pancreas, say it gets larger because of the cancer, it puts pressure on the liver, the ALP rises, ALP. Or say you've got a gallstone, it causes pressure, it puts pressure on the liver, it causes the ALP to rise. Sorry guys, just I just logged out. So for your knowledge, ALT or AST, where there's T is within liver, ALP is outside the liver. One caveat for the ALP, which does apply to you guys, is in a child, which I don't know if you see children often, or whether you'd even do the bloods for that. Probably we don't even do it, so it's not worth it. But if you ever see it in a child, ALP in children will always rise. Annoyingly, it's also a marker of bone growth. If you really had to break it down, if I went and broke, Tim's femur, his ALP would rise, because it's also, frustratingly, the enzyme that helps in healing of bones.
Yeah, and then I forgot. Oh my God, you've got a meeting. What's the universe? Not the universe. You want a meeting? No.
Joe, can you mute your mic? Joe, can you mute your mic? Joe, can you mute your mic? Thanks, Lavan.
Good. So yeah, that's just to confuse things, but that ALP, just remember, that's more in kids. So if you ever see a child and the ALP rises, don't be alarmed. It's not because they're fractured or anything like that. They are still growing. And remember, when bones grow, it's indicating that the enzyme is kicking off, and that's why the ALP would rise. So AST, ALT within the liver, damage within the liver. So you'd see that rise in things like hepatitis. You see that rise in a viral infection. You see that rise in poison, so things like methotrexate that you would use in rheumatological conditions. Just good to know. And then the ALP is either around the liver, something's going on with the pancreas, the gallbladder, or potentially in a child, you would see that rise because it does also apply for bone.
Thyroid function, TFT.
TFT. So TFT, thyroid is in every part of your body. The quickest way to describe it, it's like a battery. We all have the battery in our neck. When you have a low thyroid or low charge, everything's very sluggish, constipated, tired, muzzy head, weight gain. Your period cycles go off because they're slower. Your skin is very dry. Your hair is very dry. It's like the charge has just been drained of you. You give them thyroxine and it shoots them up and they're back to full energy. Again, think about your same, say, Duracell battery. You put it on high charge. Everything's very fast. The heart rate is very fast. They're anxious. They're sweaty. They're trembling. They're running around. Their eyes are bulging out. They're losing weight. They're getting diarrhea. And you can really, it's one of those lovely examples where it's very logical. You just think about that battery idea and you just apply it. Now, where does it help? How does it apply? Well, actually, hyperthyroid, high charge, or low hypo, more commonly low, we get a lot of muscle ache problems that start from just that. And actually, we delay picking up it because we just think, it's a bit of muscle pain here and there, and then let them carry on. Interestingly, the girdle area, pelvic girdle area, and the upper thigh is a common area where hypothyroidism is linked to. So, sometimes, you get cases where they just struggle to get out of the chair. And you think, well, they were doing that comfortably a few months ago. Definitely worth getting that thyroid function test done. Obviously, there are other conditions, things like polymyalgia rheumatica, which you would do your ESR for. I would add that on the blood test. But yeah, generally that pelvic girdle or upper thigh uncomfortable or sore pain, a very good blood test to check. And again, due to the sluggishness of it, just be wary that they may not be on top notch to perform, the physiotherapy that you want them to. And also remember, because everything's slower, weight will be a problem. So I have a lot of success with patients who the range for TSH, the thyroid hormone, ranges between 0.3 and 5. Now, what's fascinating is 20 years ago, if you asked me, anyone who was in that range would get a, yep, well done, off you go, you're going home. And they'd sit there and go, Dr. Baskaran, I'm aching, I'm gaining weight, my muscles are hurting. Yep, but your blood test biochemically is correct, off you go. Now we appreciate that, well, you could have someone at 0.5, but you can also have someone at 5 and considered normal. How does that work? And this is where we're now becoming cleverer, where if you present like a textbook, which commonly they do, where they present the hypo, low thyroid picture of tiredness, constipation, big face, dry skin, dry hair, low heart rate, all of the typical pictures, but their blood test is in normal range, I give them levothyroxine. I give them a trial. And you will not believe the gratitude you get as a doctor from these patients, because they've been pushed around for years, probably having in the same range, and you dramatically improve their quality of life, because it just happens to be, we're not thinking about biochemical now, we're thinking about them as a patient. But yeah, it's more linked to the muscle ache and joint pain that you would see in physiotherapy.
So probably one of the most familiar ones to us would be ESR and CRP. And maybe you can run through sort of when we might test for those.
Yep, absolutely. So ESR, CRP, anyone who's got rheumatoid arthritis, we always do a baseline. It's our standard, along with the ones we spoke about. We would always do that. So it gives you an indication how much, I guess for you guys, how much you can push it. Because just because they have rheumatoid doesn't mean you can't work on them. You can still provide them with great benefit, but how much can you push them? If their ESR and CRP has risen, you probably can't do your full levels. You'll need to wait till that goes down. And that's normally with their medications like methotrexate. But your kind of rough guide of ESR CRP, you are welcome to do that, because that will give you an idea. That's your monitoring over months of how well we are successfully improving their things. If the ESR is raised on a ridiculous level, and it's for no other cause except inflammation in their body, we need to address that. And actually things like steroids or anti-inflammatories, theoretically, we could add those in to try and bring these down. With the CRP and ESR, the difference is a tricky one, because ESR we tend to feel is more acute and CRP is a bit more delayed. So monitoring in the hospital, we tend to drop off doing ESRs after we've done it for the first few days after admission, because that's going to just hopefully settle or go a bit funny. Whereas CRP, you'll notice people who've got an inflammatory problem, whether it's bowel or joints, we are still doing that every few days or every week until they're discharged from hospital, watching that go down. So we feel that's more of a lag-ish inflammatory marker, whereas ESR is more acute. Where and how that applies more commonly is things like polymyalgia rheumatica, PMR. We depend hugely on the blood test, simply the ESR. If the ESR is positive and they can't raise their arms above their shoulder, it's got to be PMR unless proven otherwise. And we start steroids immediately. The reason why we panic is because it's got associated symptoms with giant cell arteritis. So this is a condition where you get inflammation of the temporal artery, and sadly that can lead to blindness. So where we get into panic mode, really, PMR, which is quite a simple thing, simple to treat, we get quite worried. And further with PMR, just watch out that we quite quickly start steroids. But the problem we have nowadays is patients love it. Obviously, they're on steroids, everything's great, they're so much better, pain everywhere is better, because as we know, steroids do have that wonderful effect of reducing inflammation everywhere, but patients don't want to let go of it. So you have a lot of patients, sadly, on quite high doses 15, 20 milligrams of prednisolone for 6, 9, 12 months because they refuse to get off it.
Great. And so maybe we can just discuss vitamin B12. Now, do we check individually for vitamin B12, or do we always group it together with folate and ferritin and vitamin D?
So B12, folate, ferritin, the pathophysiology is it's on the red blood. So actually your red blood team, so your hemoglobin, depends on all those factors. If your folate is low, hemoglobin goes low. If your B12 is low, hemoglobin goes low. If your ferritin is low, you need these vital nutrients or these essential elements in the red blood to get your red blood fresh. That's not to say your body won't make red blood. Your body will make blood, but it will make rubbish blood. It will make weak blood. It's not going to give the full. So strangely, the hemoglobin may look all right because your body is finding compensation. That's why if you're really interested in hematology, when you look at those extra things that we were talking about, the rubbish that you don't look at, the width of the red blood, all of those will change. They get bigger, they alter because the red blood accommodates because it doesn't have its essential iron, folate, B12. The way we order blood tests, though, I group them together, but when you order it, you have to order it separately because there is an argument saying, they could be on, say, folic acid. Why do you have to check folic acid again if you're already doing it? But yeah, order it separately, but it is essential when there's muscle ache, joint pain, always order those because low B12 is a big reason. Yes, number one for all of these, as you can imagine, if you've got low red blood level, is tiredness. That is your number one symptom. But second is always muscle ache and joint pain. And as of the last 5-7 years, we've added on vitamin D because it's such a common issue. And, again, just for your knowledge, the levels are very important. I mean, a low vitamin D where we give the high doses in the range of, say, 15 or 20. But we have patients who have, say, 60. They're just above the normal. 50 is the cutoff. So the lowest is 50. They may have 60 and they still come to you with, I've got quite severe muscle and joint pain. I hit them hard. I give them loads of vitamin E because the maximum can go up to is 200. And again, it's that thinking that why do we have to just be lazy and think, oh, we've just got them in range, right, move on. We have to think more sensibly. If they're still symptomatic, treat them until they're asymptomatic, because actually by getting them to a better level, we're improving things. So things like iron, so ferritin and folate, if they're not top notch, their immunity is going to be poor. Iron, if you don't have good iron, you get chest pains, headache, shortness of breath, anxiety, depression. You get a condition called pica in kids where they start eating cigarette butts or ripping off paint off the walls and eating it. You find that shocking, but I've had pregnant women who are they're taking salt by the bucket and drinking salt crystals from you might think they're mad. They're eating ice. You're watching them, they're just eating ice cream. This was it was considered a mental health condition before until 1989 or something, when they found this was due to low iron. What happens is you actually almost go through a mental health crisis where the body doesn't know how to manage or get that iron. And it almost, in a strange way, hallucinates the idea of things like a cigarette butt or paint off the walls producing or providing that iron. It's a really strange, unless you read about it, it's very hard to understand, but it basically puts your mind in a strange mindset where it feels eating those products will compensate the iron. Now you think if the human body can do crazy stuff like that, this is how important iron is. So don't let your lady who should have an iron of, say, in the 50s to 100s, she's got a level of 13 and the lowest is 12. Don't sit there and say, oh, that's fine, she's one above. When the maximum for iron is 200, get her as high up as you can, within reason. Obviously, if she's struggling with the amount of vitamin she's taking, calm it down. But it's really vital you get your vitamins in check, because not only are you going to help muscle ache and joint pain and make your job easier and your job more successful, but you are helping avoid things like low immunity and chance of getting infections and anxiety, depression, commonly caused by low iron and low folate.
And can we just go on to the ANAs then and talk about that, and what is that exactly, and how does that all tie in?
It's a simple way of saying autoimmune disease. Now, Autoimmune, I don't think gets enough credit, or people talk about it enough. It is simply your own body attacking. Now, if you think about asthma, if you think about dermatologists, so skin conditions, hay fever, things like rheumatoid arthritis, a lot of conditions we talk about, we don't actually appreciate that it's our own body attacking. And it's an overreaction of our body. So asthma is actually an overreaction in our lungs. The body thinks, you know, say an allergen comes into the inside of the lung, and the body, rather than just clearing it and moving on, attacks that area, releases its chemicals, hence causes what we call bronchoconstriction, or the thinning of our bronchioles, the way we breathe. We then take steroid puffers to open that. So you think your own body has actually caused that. It's not because you just one day woken up and you just develop asthma. It's actually an autoimmune condition. Your own body is actually doing it. It's linked to other conditions. So hay fever, eczema. Eczema is actually your own body attacking your skin, thinking there's a problem there. People don't think about it like that. They just think, oh, poor guy, they've got eczema. Psoriasis. Do you think those plaques, those large areas, those very sad conditions, you know, sad areas of skin that, you know, sadly those patients get very depressed about? It's not their fault. Their body is attacking. And why I'm saying it's important is, what's the answer to every condition I've just mentioned there? Steroids. We give steroids to asthma. We give steroids for psoriasis. We give steroids for eczema. The best hay fever medication is a steroid. If I give you an injection in the bum of high dose steroid, I guarantee I won't see you the whole summer, because we can give steroids in the bum for stopping. And all it is because the hay fever, the idea is actually the pollen or the allergen or the tree or the grass or the dog fur or the tomato you've eaten. When that enters your body overreacts in a panic because it doesn't like it, doesn't deal with it for some sad reason. So it sends all its troop, it sends its platelets, it sends its eosinophils, it sends all these weird and wonderful characters, overdoes it, and then starts blocking areas, causing blotching, causing a lot of energy spent there. Therefore, you go into septic shock and blah, blah, blah. So this is why ANA is very important to ANA, because it groups a lot of the weird and wonderful conditions. So things like lupus, Sjogren's, which I briefly just started with, where you get the dry eyes and dry mouth, that doesn't just appear. Your own body in the condition known as Sjogren's syndrome. Fascinating conditions. If you ever read or see a patient, they don't produce teardrops, and we do it with a test where we actually put almost like a litmus paper, and we can see that it doesn't, you know, it doesn't moisten. It's a condition where the body attacks the salivary glands and the lacrimal gland, the eye tear duct. It's fascinating, and you think that's not because they just woke up, but their own body decided one day, I don't like your tear duct, I'm going to attack it. And we treat, so ANA is a very good blood test, because if there is an autoimmune condition, and particularly in your kind of work, things like juvenile chronic arthritis, which you would see in children, mixed connective tissues, things like scleroderma. I don't know if you see that very much, but it's this idea where the body attacks the collagen, which makes up our tissue. And you see sometimes these women with stretched skin over their nose. They look wonderful. They look very beautiful. For 80, 90-year-old, they look stunning. But it's because they've almost like had Botox in their own way. Their skin is stretched like this. And we call it almost like a beak form. Their nose cartilage is stretched like this. And that happens all around the body, and that's their own body attacking. So ANA can pick up, or ANA can pick up those kind of conditions. So in your case, juvenile arthritis, polymyositis, which you may see, rheumatoid arthritis, scleroderma, Sjogren's, and lupus would all be, just because you have ANA doesn't mean you have all of those, obviously. It just gives an indication that we need to look into this further.
Brilliant. Well, that's probably, I think, one of the most useful CPDs we've had, and most relevant as well. So I'm going to pass now and ask anyone to jump in if you unmute your mics, and please feel free to ask Lavan any questions.
I'm conscious there's a couple of questions on the comments as well, Tim. Which
yeah,
we can address
so Karen, do you want to ask yours, and Kay, do you want to ask yours about Anki-Spon, and Karen, I think you were asking about fibromyalgia.
I'm happy to ask mine again, Tim.
Sure.
Yeah. So if I had a patient that I suspected possibly with Anki-Spon, what type of bloods would he need to go and have?
Good. No, good question, and we don't do enough of it actually. It's actually really one blood test that would diagnose, and it's a blood test called HLA-27, and we have that on the request. That is your one that will diagnose. But just remember, although you're very suspicious and you probably are right, it could also be other things as well. So while you're doing the HLA, which is the key, do add on what I've just said before as well, because the worst thing you want is it comes back and by chance it doesn't show as positive, or weakly positive where it doesn't always read, but it's the HLA-27 that you're looking for.
And is that done from a GP, or was, because traditionally wasn't that always done through rheumatology, or can that be done through?
So now we are allowed to do it just because, you know, in the most respectful way, someone knowing they have ankylosing is sometimes good enough for them. It allows them to manage their condition better, you know, because it may be where they're just curious, their uncle had it, they just want to know because, you know, they've got a bit of an ache, they just want to know how they want to address it. So no, we do it now in general practice as well. So it's one of the blood tests we can request.
Brilliant, thank you.
No problem.
I just wanted to ask about fibromyalgia. I know the diagnosis has changed. I remember in the old days it was certain points in the body, but I understand that's different. And I had a lady the other day who I suspected of it because she had very poor sleep and she was about 70, but pain all over her body.
Yeah, a tricky one, isn't it? Fibromyalgia, you know, you've got 50, 70% of GPs, not even GPs, doctors, not even believing the condition exists. You've got 30% of us who believe in it, but we're stuck because there's no blood test that says you have fibromyalgia. It's a diagnosis of exclusion. And that's the tricky part of it. So when we do the blood test, if you a really good guy, I'll pass it on to you, Tim, when I remember tomorrow, the St. Helier's blood screen for fibromyalgia. It's a really wonderful document. If you're really interested, the information they give after when you're diagnosed in terms of you know, giving antidepressants or B12 injections on how to manage it, because we accept it's not a condition that can be cured. It's not a condition that has a fixed blood test diagnosis. It's a diagnosis of exclusion. And if Tim can pass on that blood test form for you or the request, it's crazy. It literally is exclusion. So it's everything I've just told you, including the ESR, the vitamins, all of that. It goes on to even further autoantibody screens. So antibodies that detect, say, the gastric area. They do this whole list where you literally go through everything. And if everything's negative, so if your vitamin D is low and you're dead set this is fibromyalgia, they will not accept the referral. You have to get everything back to normal range to prove that this could be fibromyalgia because everything else is normal. So we literally have to, and they won't accept the referral if you miss out a blood test or the ESR 3 months old. You literally have to tick, and it's really easy. It's exactly what they ask for. Tick, 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 send it through. And then once they've accepted it, it's about, you know, if you look at the criteria of the diagnosis, it's ache all around the body at multiple points. It's ongoing kind of sore throat, fogginess, headache. It's a really multi-system disorder. And again, the theory behind it is, if you go, we're not sure if it's autoimmune. We have to assume there is some element of it, but it's your body almost attacking all parts. Now, the frustration comes as clinicians and for the patient is we really feel we can't manage it. We don't know what to do for these patients. And so when we refer, they expect the rheumatologist or the specialist in fibromyalgia to really do something. And sadly, they don't. It's in a way clever tricks, I think, where they give amitriptyline high dose. They block the nerve to that whole body. Obviously, if you give 50 milligrams to 100 milligrams of amitriptyline, you're going to do something. You're going to block nerves in a good place. They do that. They whack in high dose B12 injections that we typically give for low vitamin B12. They give it even if it's low or high. They give antidepressants. There is actually sertraline when you're increasing the levels where you're actually giving kind of the happy hormones are going up. Does that have a positive impact on things? So the serotonin, when that's released, if you have more serotonin in the body, does it dull pain around the body? Possibly. So it's really a bit of a cocktail of playing around with things. And it's a really, for me, it's frustrating because I feel I'm not doing enough for the patient. The patient knows we're trying, but also gets fed up because they live their life like this. So How do we diagnose? Yeah, I think if you're really interested, it's a wonderful document referral form. It's actually a referral form, but it's almost like the A to ABC of how to manage fibromyalgia and what blood tests we do before we diagnose it, and what condition, what symptoms, so the headache, sore throat, the ongoing tiredness, the muscle ache, joint body pains, affecting everywhere, acute or chronic. But I can send that over to Tim.
Josh, did you have any comments to make?
Yeah, sorry. I was told by a GP a while back that she was saying to me that you could ask for ESR, CRP, NT-CCP, and rheumatoid factor, but she was telling me to be quite cautious about ordering HLA-B27 because she said it was due to cost. What are your thoughts about that?
Absolutely. Where do you work?
I work in Wellington.
Okay, cool. Yeah, it really
you'll know which surgery, Lavan, so you can't.
Yeah, exactly. I think if you come to my surgery, you'll get MRI scans and CTs like it's sweet. So, no, he or she who's told you that, it's fair. I'm joking, but the NHS, we have to. Let's be honest, we do have to protect the NHS. I have a lot of respect for physiotherapists. So if you guys have a suspicion that this could be ankylosing spondylitis, I think it's really disrespectful of me to say, no, you can't order it or it's too costly. I would give you full credit to order it. And if it's negative, so what? I think if it's like your general screen, like I was telling you, we do kind of full blood count, user-knees, LFT and TFT. And if I just randomly started seeing HLAs just being added on, I'd then get a bit like, guys, come on, what are we doing here? But no, if there's enough clinical suspicion, I guess with a lot of these things, you need to be able to justify it, don't you? So if there's enough there where, the rhyme that I used to learn from medical school of the 6 A's or 7 A's or whatever, if some of those are there, radiological appearances fit in with that, whether you document it or whether if someone were to give you a marginal hard time and say, oh, why are you... But I guarantee that same doctor is probably the one ordering, silly amounts of ESRs for something else. So yes, we all have to be respectful to each other, and so depending on where you work. But I don't think it's unreasonable to at least then say, if that's the environment you're in, to at least could I order that, because I think there's a suspicion here. And I would appreciate, if someone came to me and said that, I'd be grateful you'd even thought of that, because I think the problem with the way the system is, because we've got so many patients, so many conditions to think of, I'll be honest with you, now that you've mentioned ankylosing, I'm going to order probably a few more than I would do this month, just because those patients that come in, I'll be honing in on it a bit more. Whereas because I haven't heard of ankylosing spondylitis for the last month and a half, I can tell you now, I haven't ordered an HLA for a good 3-4 months. But maybe a couple of the ones, if I analysed or audited those patients in the last couple of months, I probably could have. So in answer to your question, yes, depending on where you sit, how your relationship is with a doctor. So where's James? If James was, I think he was on here. James, he can do what he wants at our practice. If he wants to order it, he can. But yeah, just be respectful of their guidance. I mean, it may be, they've had a bit of a beating from the CCG for ordering too many medications or something. So they're a bit more cautious. But at least ask. Don't feel you shouldn't, because what a wonderful thing if you do that blood test and you correctly diagnose it is. But that's credit to you.
Would you order the same kind of bloods for, say, like an axial spondyloarthropathy compared to like a peripheral? So
say that again.
Would you order the same bloods for if you were thinking more like either between axial? I mean, they're two different presentations, but if it's like an axial spondyloarthropathy or a peripheral spondyloarthropathy,
yeah.
Would you still be thinking your similar kind of like ESR, CRP, and then your NT-CCP and rheumatoid factor? Is that what you would go with first?
I would still go with that first, exactly. You're chucking the net out there, aren't you? You're getting a bit of a rough idea, because it could all come back negative. And remember, part of this is the patient journey of reassurance. When we do blood tests, yes, it's for us to diagnose, yes, it's for us to make an opinion, but it's also to reassure the patient. They may be really anxious. Oh, doctor, I saw you ordered 7 blood tests. I'm really worried about. I read about anti-CCP, rheumatoid arthritis. Apparently, my lungs will die at some. So actually, getting these done, you're painting a more confident picture that when you speak to the patient, even if you get negative results, that's a positive. If that makes sense, you're giving reassurance.
And if it's positive, would you just refer them on to rheumatology straight away then?
Yeah, I mean, we would love that as GPs in terms of, you know, we're the same league. So it'd be disrespectful for you. I mean, you can come to us to discuss it. Lavan, really interesting case. What do we do here? Should I do this? Or of course, should I start steroids, for example? This, so an example would be definitely rheumatoid, maybe anti-CCPs raised, good story for rheumatoid, but really struggling day to day. Waiting list for rheumatologists is 6 months. Come and have a chat with me. Why don't we start some steroids? Why don't we do a sliding scale, 6 a day for a week, 5 a day for a week, 4 a day for a week, 3 a day? Why don't we keep that going till they see, let's improve their quality of life? Or if you just think, you know, this is good going, I don't want to bother the GP, you know, they've got a million things to do, I'd be happy with that. Because we do want to get into a place, I think, where so some of my peers, physician associates and paramedic I have here, they used to run everything by me, but now they know how my mind works and they know, yeah, I'll refer that on because it will save Lavan trouble. But he probably needs to have a chat or wants to chat about this for things. But no, in an ideal world, if you could refer, that would be lovely.
Sorry,
can I jump in?
Yeah.
Are you still asking?
Sorry.
The same. Lavan, I think we've got certain criteria for the early inflammatory. I know that the rheumats love ordering anti-CCP and ANAs. They
Yes.
regularly do that.
Yep.
And I think that's their main criteria for any RA cases, because seronegative cases may also pop up, like you said. Although I think they are very keen on patients who fit that criteria. You know, more than 30 minutes of morning stiffness, more than 3 DIP joints tender, you know, sort of any inflammatory conditions or any infection of the eyes. They're very, very specific to those conditions. They want to see those patients pop up, isn't it? It's better to come and approach you all if it's not hitting that criteria. Am I right by saying that?
Correct, exactly. Which is why initially the blood test, although in an ideal world in the NHS, every single person that maybe comes through your door, if we had free money or blood tests and cost anything, I would still say do the whole whack in one go as your first panel. However, because it is the NHS, you'll see junior colleagues, for example, and it's not frustrating because I was like that when I was younger, but say my junior partner, for example, you know, when she's doing blood tests, because she screams, she literally, but it is that idea that if you look for everything, you will find some weird and wonderful things. So my thing is, if they come in for quite basic, average, below criteria issues, I would do the basic screen. I would do vitamins. I think that's really because I'm a big fan of improving quality of life. And therefore, if their vitamins are good, I'm thinking holistically, I want to improve their mood, their immunity, as well as their musculoskeletal joint pains. But I agree with you. You would not see me doing anti-CCP, ANA markers, all of those in a first setting, unless you get, you know, the last time I can think is that we had one Polish girl who came and said there was like a strong family history. And it was, she was right. We picked up and she definitely, and it's that's quite fulfilling because, you know, we've listened to the patient. The patient's really satisfied that you've listened and understood her concern. But I agree with you. I wouldn't just do the full net on first go. Get more of a history. And that's the beauty about blood tests. If they're not acutely unwell, let them come in and then, you know, have a chat with them. And you're going to follow them up probably, or one of your colleagues will. So do the second round after that. No harm in that.
Great. I think final question from Karen, then please, Karen, and then we'll wrap up because we've got a part B, which I think Lavan's very kindly offered to do in a couple of weeks, where we might try and look at a couple of cases or look more specifically at some sort of real world examples. Karen?
Just a quick question. Do you prescribe vitamins, or is it okay just to get them to buy them in the supermarket, or do you know, any advice on that?
Yeah, absolutely. So yeah, if you're really stingy as a GP, you tell them to go and get everything over the counter. The problem is the dosage and the way they're prepared. Things like vitamin D, for example, are quite tricky to get at 20,000. Iron as well, the good stuff is typically prescribed. So I would say if it's just like minimally raised, so vitamin D, a good example is if vitamin D, if you need to hit 50 and you're on about 42, my standard text message is your vitamin D is a bit low, take 1,000 units over the counter, done. However, if they're 12, I would send a message going, I'm sending you 20,000 units 3 times a week. I've sent it over to your pharmacy, take that. Similarly with iron, the iron that you get over the counter is never going to be as strong as the stuff we give you. So we have the ferrous sulfate, ferrous glutamate, gluconate, ferrous sulfate, ferrous fumarate, ferrous sulfate, ferrous gluconate. And we have quite strict instruction, because if your ferritin, which should be in the range of 12 to 200, which is a bit ridiculous, let's say we needed to hit 50 and they're 3, I would give them my stuff with the advice, if you may know, that ascorbic acid or vitamin C absorbs your iron better from 10 to 40%. When you take an iron tablet, you only absorb 10% of that iron tablet. 90% comes out the back passage. You take orange juice with it, it ups it to 40%. Still not great, but it's okay. So yeah, I think if their levels are low, we would give, and that applies to folate. Again, I would say go and buy it over the counter, but if I'm really worried your folate is low, I would prescribe. I have more control, because actually on my EMIS, I can monitor how many I've given, when I'm due for follow-up. And remember, B12 is an important one. B12, you can give it in sprays, you can give it in tablet form. However, the best way you give vitamin D is through an injection, IM. And you see now nail parlors, genuinely nail parlors in Sheen are selling vitamin B12 at £50 a pop, legal apparently, because it's common sense. If everyone's going to have a little bit of lower vitamin, you're just giving someone a vitamin boost, but they're getting so much energy from it, and they're getting at £50 a shot. Here, we wouldn't do that. I can't, unfortunately, Tim can't come and say, Lavan, I want some vitamin D. I could stab you. No, I'd have to do a blood test. If that's low, then yes, I could put you on a regime. First 2 weeks, we give it 3 times a week, jab, jab, jab. And then after that, it's every 3 months. But you are welcome to take oral or spray every day to maintain that B12.
Lavan, thank you so much. I think that was just so useful. So if it's okay with you, can we pest you in 2 more weeks?
Absolutely.
That'd be amazing. And I have here 19 physios left who are at your disposal to film any information, any musculoskeletal condition. So Lavan has a brilliant YouTube channel, and he talks about musculoskeletal conditions. So if anyone's interested in doing that, please reach out to Lavan. If you've got any particular interests, any particular specialisms, anything that you want to get on video, speak to Lavan, go over to his GP surgery, he'll film it and put it on his channel.
Absolutely. And if you have any big subject questions, family member, cancer, or some low, our aim here is to try and educate the population. YouTube and these things are wonderful platforms. So if there's a topic that you think we don't really talk about enough, I'd love it if you email or send it to Tim, or I'm on Instagram and YouTube. If you wouldn't mind subscribing, we'd be really grateful. But if you wanted to just put that down or let me know, I'd love to do a video on that, because these are things that I just want to get on a basic level. This is not to teach you to suck eggs, but there's a lot of things that we do learn in medical school we subtly don't realize we've been taught in a very basic, nice way. And we'd love to impart that information, because if you guys understand that better, you're going to treat our patients better, you're going to inform them better, and in the nicest way, that's going to make my job easier long term. But I do want to thank you for all the work you're doing, because it really has, physiotherapy has made such a big impact on this whole primary care network and FCP.
Brilliant. So such a good relationship, and really thanks so much. So we'll break there, and we'll see you in a couple of weeks, guys. Take care. Thanks, Lavan.
Take care. Bye-bye.